Welcome to the Explainer. Today, we're going to step right onto the floor for a clinical shift, and we're going to discover how patient problems that seem totally separate are actually, and often, deeply connected.
So here's our game plan for the day. We're going to follow a few different cases, starting our rounds with the kidneys. Then we'll tackle some blood disorders, and finally we'll respond to a cardiac emergency. And by the end of it all, we'll see exactly how they're all linked. All right, let's dive right in. All right, our shift kicks off in the renal unit. This is where we see what happens when the body's incredibly sophisticated filtration system runs into trouble.
Okay, meet our first patient. He's a 72-year-old who came in with fatigue, swelling in his legs, and a really sharp drop in his urine output. Now, these are classic signs that something is wrong with the body's filtration system. We're definitely suspecting the kidneys, but to be sure, we need to see the data.
And here we go. The initial blood work is back. You know, every number on this report is a clue, a piece of the puzzle. So what story are these numbers actually telling us?
Okay, so these labs, they paint a really clear picture. Look at the serum creatinine and the BUN, that's blood urea nitrogen. They're both sky high. This is a huge red flag that waste products just aren't being filtered out. But you know the real danger signal here? It's that elevated potassium. When the kidneys can't get rid of it, it builds up, and that can be incredibly dangerous for the heart's rhythm.
Yep, these labs confirm exactly what we were thinking: acute kidney injury, or AKI. We're literally watching the body's filter fail in real time. Waste is building up, that potassium is climbing, and that's a direct threat to the heart. The clock is absolutely ticking. We have to intervene, like right now. So, when kidney failure becomes a long-term thing, dialysis is often the next step. And really, there are two main paths. On the left, you've got hemodialysis, where a machine outside the body, basically an artificial kidney, does all the work, usually at a clinic. On the right, there's peritoneal dialysis, which is pretty clever. It uses the body's own abdominal lining as a natural filter right at home. As you can imagine, this choice dramatically impacts a patient's entire daily life. Okay, let's head over to our midday cases and see how this all builds. We're shifting our focus now to hematology, disorders of the blood itself. And just like that, midday brings a totally new challenge. We've got a patient with sickle cell disease who's in a pain crisis and needs a blood transfusion. Now, this is a life-saving procedure, something we do all the time. But here's the thing, routine can never ever mean we let our guard down. You've got to be watching like a hawk for any kind of adverse reaction.
And this is exactly what you're looking for: fever, chills, a racing heart, or that very specific low back pain. The second, and I mean the second, you see any of these signs, your hand goes straight to that IV line. You stop the transfusion. That is always the first and most critical step. No hesitation.
Okay, now let's shift gears a bit and talk about anticoagulants. You know, medications like heparin are incredibly powerful tools. They're amazing for preventing dangerous blood clots. But, and this is a big but, getting the dosage right isn't just important, it is absolutely critical for patient safety.
So you see this number, 1,250 units per hour? That is not just a random number. It's the result of a super precise calculation based on the patient's weight, their blood clotting time, everything. Getting this right is, well, it's everything. Think about it, a single misplaced decimal point could turn this therapeutic dose into a life-threatening one, causing massive bleeding. There is literally zero room for error here.
And you know, our job doesn't just stop with IV meds. For patients who are going home on oral drugs, like allopurinol for gout, our teaching is what's going to keep them safe long-term. And it's simple stuff, right? Drink plenty of water to protect your kidneys, take it with food to avoid an upset stomach, and call us immediately if you see a new rash. This is the kind of teaching that prevents a manageable condition from spiraling into a really serious complication.
Okay, so the afternoon is rolling on. And then we get the call. A patient with chest pain. It's time to pivot and focus on the body's engine, the heart.
Yeah, this is the call that gets everyone, and I mean everyone, moving. A myocardial infarction, a heart attack. In this situation, there's a saying, time is muscle, and it's true. Every single second that blood flow is blocked, precious heart tissue is dying. We have to be fast, and we have to be precise. This is a flat-out race against the clock. So at time zero, you're assessing airway, breathing, circulation. Within 2 minutes, you need that ECG in your hand. By 5 minutes, they're on oxygen, and they've gotten aspirin. By 10 minutes, we're giving nitroglycerin to try to open up those arteries.
See how fast this is? Every single step is laser focused on one thing. Get that blood flowing again and get this patient to the cath lab fast.
Okay, so once the immediate threat is handled, the blocked artery is open, our job completely shifts. The danger isn't over. That heart muscle is damaged. It's irritable. So now we're on high alert for the aftershocks, those dangerous arrhythmias.
For some of these patients, a pacemaker is literally their lifeline. But how do we actually know it's doing its job? Well, on the ECG, we're looking for this tiny little blip. We call it a pacer spike. That's the device firing. But here's the crucial part. We need to see that every single spike is followed by a heartbeat, what we call a QRS complex. We call this capture. It's proof the pacemaker is successfully telling the ventricle to beat. The patient's heart rate should match the pacemaker's setting, and, the most important sign? They should feel better. No more dizziness. The real battle against heart failure? It's won at home. This isn't just a list of instructions. This is the patient's toolkit for staying out of the hospital. Weighing themselves daily? That catches fluid buildup before it's a crisis. Cutting back on salt? That takes a huge strain off the heart. Taking their meds is just non-negotiable. And teaching them the red flags? Like, hey, if you're getting more short of breath, you need to call us. That empowers them to get help before it becomes a full-blown emergency. Okay, our shift is winding down, but this is where it all comes together. This is the most important part of the day, seeing the big picture. So let's think all the way back to our very first patient this morning. Remember our guy with the acute kidney injury? Right. His problems started in the kidneys, but it never, ever just stays there. The link between his failing kidneys and his heart, it's a classic, critical example of just how interconnected all these systems really are.
And here it is, the chain reaction, the domino effect. It starts when the failing kidneys can't produce a key hormone, erythropoietin. Okay, so with that, the body can't make enough red blood cells. That leads to anemia, which is a blood problem, right? So now, domino number 2 has fallen. Now the heart has to work way, way harder to pump that oxygen-poor blood everything it needs to go. Over months or even years, that constant strain just wears the heart out, eventually leading to heart failure. You see, a kidney problem becomes a blood problem, which becomes a heart problem. It is all connected.
And this quote from William Osler, man, it just perfectly captures the essence of our entire day. We're not just treating a set of bad lab results or a single organ in isolation. We are caring for a whole, complex, interconnected person, where a problem over here can have massive effects way over there. So, this is the crucial takeaway from our whole shift. Always look for the next domino. When you see a problem with the kidneys, you have to be thinking about the blood and the heart. When you see a cardiac issue, you got to ask, where did this really start? Thinking systemically, seeing those connections, that is what separates good care from truly great care.